Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I wanted to welcome you all to today's live webinar hosted by WellSky, and it is called Beyond the CMS Star Rating, Bridging the Gap Between Acute and Post-Acute Providers. And I'll tell you a little bit more about WellSky in a few minutes, but I'm very excited to hear from our speakers today, which I'll introduce momentarily. A few items of note before we get started. Everyone is joined today in listen-only mode. It's a traditional webinar format, so you don't need to worry about muting your microphone or turning off your camera or anything like that. We can't see you or hear you, so no worries there. However, as I always say, we do want to hear from you. So we're going to have a time for some Q&A towards the end, and we're going to get to as many audience questions as we can today. We have quite a big audience. But if you have a question, go ahead and drop that at any time into your control module, which has a specific place for questions, and you put them in there. We're going to get to as many as we can. If for some reason we don't or aren't able to get to yours, don't worry, someone will reach out to you via email afterwards. So even if we're wrapping up at the last second, go ahead and ask your question. We're going to get to as many as we can. And then finally, the session today is being recorded. So what's going to happen is when we're done, you'll receive an email from one of our team. It may be an hour or two after the recording, and there'll be a link to, or after the presentation rather, there'll be a link to the recording as well as where you can download the slides and more information about contacting the team, etc. So again, thank you for joining us. Without further ado, I would like to briefly introduce our speakers today. First of all, we have with us Ms. Marie Rosenthal, and she's the Senior Administrator at Arch Care. So welcome, Marie. And we also have Esther Panday, and she is Vice President of Care Transitions at Mount Sinai Health System. So I believe, Esther, you're going to get us kicked off, and look forward to hearing from you both. So welcome to you.
Great. Well, thank you, everyone, and thank you to the VBC Exhibit Hall for having us. Let's go to the next slide. So we're going to I'll start off by giving you a little bit of information about Mount Sinai Health System. We are located in New York City. We have, all right, we'll go over, we'll talk to you a little bit about, the CMS star rating and talk to you about our collaboration with our post-acute care partners that goes beyond that basic CMS star rating, and then focus on how we achieve the high-performing network and some of our outcomes. Next slide. So Mount Sinai Health System, we are located in New York City. We have 8 acute care hospitals, approximately 4,000 hospital beds. We have 7,000 physicians, 43,000 employees. We do over 3.5 million patient visits annually. We are over 11 billion in revenue annually. We have a school of nursing and a medical school, and we have over 400 network outpatient practices. Next slide. So as you saw, I spoke a lot about our brick and mortar, but we over the last few years have expanded out into the community with many programs such as hospital at home, PAL care at home, rehab at home. We have a home infusion, home health care services, home dialysis program, community paramedicine program, remote patient monitoring, and visiting doctors as well. What's missing and what we're really here to talk to you about is we don't own any of our own skilled nursing facilities, and we really rely on partnerships to service patients at that level of care. And it's really important for us to identify high quality facilities to send our patients to. Let's go to the next slide. Mount Sinai Health System is also an accountable care organization. We have over 14 value-based contracts, close to 500,000 lives that we are at risk for. We have shared risk, global risk, and various risk arrangements, as you see here, with commercial payers, Medicaid, Medicare and Medicare Advantage plans. So managing quality and cost of care is a high priority for our health system. Next slide. So again, if you remember, we do a lot in the home-based setting, but nothing related to skilled nursing facility care. And as a system, we discharge over 8,000 patients to subacute or skilled nursing services. Our ACO has over $100 million in post-acute care spend just on subacute rehab. And when we look at our market where we are in New York City, in a 10-mile radius of our main hospital that's on the Upper East Side, there are over 130 skilled nursing facilities. As you could imagine, that's too many to partner with and to have meaningful relationship with. We really have to think about how do we evaluate who these high quality partners are. How do we create really important clinical collaboration that's meaningful for both sides? That's a lot, right? 130 providers to really understand what's happening to our patients across such a large number of facilities. Next slide. We also know as conditions of participation for us at our 8 acute care sites, we have to follow the CMS rules. And we know that in 2019, they revised the discharge planning rules for us and really started requiring hospitals to assist patients with identifying post-acute care providers. Back in the day, if many of you remember, 15 years ago, 20 years ago, you would walk up to a patient and you would say, hey, you're being recommended for subacute rehab. Here are a list of facilities within your zip code or within your borough, region, geography. And you'd kind of walk away, right? And you'd come back and say, did you select 5 facilities? Do you have a top one that you prefer? And you really didn't engage, right? Because there was a lot of concern about, the steering, the prohibition about steering patients to specific providers, not wanting to be held accountable, if you recommend the wrong facility for a patient. And now CMS is kind of saying, no, you as the hospital and the discharging really have to start talking and assisting and educating patients about what it is that they're choosing. Next slide. And the guideline went even further by saying that you have to share data, right? And the question is what data, right? It has to be quality measures. It has to be the same for all partners. And where do we get this data? We know CMS has their own information, which we'll talk about and look at. But what do quality measures mean for us? What does it mean for CMS? What does it mean for the patient, right? What is the correct data? What's the correct source of the data for this information? So, we're really interested in seeing where this regulation continues to go, because we know that there's going to be more and more pressure as Medicare continues to expand their value-based programming. We know that, for instance, for us, part of our value-based hospital incentives is looking at cost of care for our beneficiaries that leave our hospital, right? So really educating our patients on these things is really important as well. And we're seeing that the guideline is now really trying to push to educate the consumer around quality measures, cost of care, and not only requiring it on the hospitals. Next slide. So obviously, a lot of people default and say, okay, great, let's go to cms.gov, nursing home compare, and let's look at the data there and use that and share that with patients. On the left side here, you see some of these very high level data points that CMS shares, their overall quality measure, health inspections, staffing, quality measures, COVID-related fire safety, penalties. And I'll be honest, as a consumer, as a patient, do I really, what is health inspection? I don't know that I understand what that is. But even when you click down and start looking at the details under some of these, and on the right here, we have, for instance, some of their quality measures. As you could see, there's a mixture of short stay measures, long stay measures, if I'm being recommended for subacute rehab, which we as a hospital, I would say 90% of our discharges are for short stay, not long stay. Um, but if I'm a patient looking at this, do I need to worry about the short stay measures, the long stay measures? What does that mean? Again, there's so many here. You have things related to bowel incontinence, but if I'm someone who's just planning to be there for 20 weeks, I'm younger, maybe 65, just had a hip replacement. Do I need to worry about bowel incontinence outcomes at a nursing home? It could be really confusing, right? And for us as a hospital, again, understanding that long-term measures are very important for residents that need that level of care. There are really only 5 short-term measures that CMS takes into account. And majority of my patients are going to rehab facilities seeking short-term care, not long-term care. So next slide. So I'm gonna, we pulled up, 3 facilities, SNF ABC, that are near our hospitals. So 3 of the 130 in our area. And we said, okay, let's take a look at what CMS would tell us about these facilities. Their overall rating, health inspections, staffing ratios, and their quality measures. And let's see what would happen if we use the CMS star ratings to decide who should be part of our preferred high quality network. And so I think, we're going to do a poll now. And Garrett, I'm going to kind of ask you to join back to help facilitate that, to see if these are the measures that we're looking at. I'd like to get a sense from the audience. Who would you choose to be in your network?
Okay, so take a quick study of the slide in front of you, and then I'm going to pull up the choices, A, B, or C. So here we go. All right, so the question is, which SNF would you select for your network? An A, B, or C? And we've got the results coming in, so we're going to give it a few more seconds. And then what I'm going to do is also share the results with you, so you'll be able to see what your colleagues have voted on. And I think most of the results have come in, so close it down in about another 5 seconds here. Go ahead and cast your vote. 5, 4, 3, 2, and 1. Okay. Esther, are you able to see the results?
Yes, so 66% chose SNF A. I'm not surprised, right? They had 5-star overall quality. We have 19% that said SNF B, and 15% selected SNF C. Let's go back to our slide and take a look at that. So we know majority chose SNF A. Makes sense, right? They have the highest overall, they have the highest health inspection, the lowest on staffing ratios, but 5-star quality. So let's take a look. Let's go to the next slide and let's take a look. Let's drill down on some measures here. So SNF A, we have here, they're a 5-star overall quality. 65% or more of you chose them to be in your network. Again, I am a hospital health system. Readmissions are really important to me. But when I look at their rehospitalization, they have the highest one. So it kind of makes me sit back and say, gee, do I want to have in my network the facility that has the highest readmission rates? Let's take a look at, the measure underneath there that looks at outpatient emergency department visits. Again, they have the highest number of ED utilization. So again, both as a health system, right? I don't want people coming to the ED that don't need to be there. It causes bottlenecking and patient boarding. We definitely don't want anyone being readmitted. And when I put on my ACO hat, right, my accountable care, where I'm responsible for total cost of care, well, hospitalizations and ED visits that are not necessary are just going to be increasing total cost of care for patients. So gee, that basic CMS overall view really didn't get me to where I want to be in my network. Let's go to the next slide. Let's continue to drill down and see if we made the right choice. So preventable readmissions, right? So here we're talking about things like heart failure, COPD, dehydration, UTI, which we know should be well managed in a skilled nursing facility. And again, none of them are different than the national average, but when we in our market, again, SNF-A having the highest preventable readmissions. Again, not great for me when I'm thinking about choosing my provider and what's meaningful to me as both an ACO and a hospital. When we look at infections, again, really important for us, especially we perform a lot of cardiac surgeries. We are a large health system. We do transplants. We do obviously all orthopedic surgeries, spinal surgeries. So surgical site infections and all infections are really critical and important to us. And again, SNF-A is not only the highest out of these three in our market, but they're also worse than the national rate. So, I'm getting a little nervous just using those basic CMS overall star rating. And then when we think about that Medicare spend per beneficiary, so two things. One, as an ACO, that's really important to me because that directly impacts total cost of care. But on the hospital side, it affects my value-based purchasing agreements with CMS. And what I see here is that SNF-A is the highest cost setting as well compared to the other two. All right, well, let's keep going. Let's see, what else could we learn? How are you all feeling? Should we redo the poll and see, do we want SNF A, B, or C now?
All right, let's redo the poll and see what the audience has to say here. So you will see the same question from before appear on your screen. So go ahead and vote again. Same as before. Just choose one, and we're going to let the results come in. Give it about 30 seconds here. And then we're going to share the results with everybody. Okay, looks like most people have voted. About 5 seconds. And then we'll close it down. 5, 4, 3, 2, a couple more creeping in, and 1. We're going to go ahead and close it down now, and we'll share the results.
All right.
Okay,
Well,
are you able to see it?
Yeah, do you want me to share the results, Garrett?
Oh, can you see the results?
Yeah.
Oh, yeah, so interesting. Did you want me to, do you want to stay on this, or do you want to go back to the slides?
No, yeah. So, I just want to say, right, so when we started doing a little bit of a deeper dive, right, we kind of, majority, I think only 7% now are looking at SNF-A as being in their network. We have a high, 60% or greater are now looking at SNF-C, and 30% are looking at SNF-B. So suddenly when we started really drilling down on some of the details behind this, we started changing our tune a little bit, right? And you're all kind of going through our journey in a shorter time frame, kind of the journey that we went through at Sinai trying to figure this out. So let's go back to the slides.
Hey, pretty interesting. Well, there's going to be one more. Spoiler alert, so pay attention.
Yeah. All right. So, again, let's look at, let's look at some more of the CMS measures and what's on the CMS Compare website. And, overall, it looks like where SNF-A does well is on falls, which is pretty important, right? Because falls are, one of the reasons we worry about patient, going home and having a fall at home, right? Not having the right resources. So we want them to get the rehab that they need to then be able to have that safe transition. We know falls with injuries again. Both we as a hospital focus on falls a lot internally, and so it is a high value area. And so this is somewhere that SNF-A does well, right? We want to give them credit where they do a really good job. I don't know about all of you. I'm still kind of trying to understand, though, where that 5-star quality is coming in, right? So let's go to the next slide. And here we see the big difference when it comes to, where SNF-A does better than B and C, but it's on things like flu and pneumococcal vaccination. My thoughts are, one is we do a pretty good job at our health system offering these things for patients while they're on the inpatient side. We are very aggressive with it on our outpatient side. We don't need subacute rehabs to be pushed. Yes, it's good that they do it and they should, but is that the area that is the highest priority for us to excel in, for them to excel in? Probably not, because we do a really good job internally ourselves managing this, right? What we need them to be doing is taking our patients, rehabbing them without readmitting them, without sending them to the ED, treating them in place for things that are preventable, and then sending them back into the community and to our PCP for follow-up. Right. So the big difference here, I'll be honest with you, this is probably the least important measure for me as an ACO and as a hospital system for a facility. It's good. Everyone should be doing preventative care and vaccinations. But if this is kind of, when I'm sending you patients that are sick post-surgery, I want you focused on their rehab, their infections, preventing infections and things like that. So let's go to the next slide. So, the other thing, so as I said, Mount Sinai, we're an academic health center, we provide tertiary care. We get a lot of transfers. We're world renowned in cardiac surgery. We provide services such as transplants, right? Gender affirmation surgery. So we need facilities, right? Those are the patients, these really high acuity patients are the ones that we're sending to facilities as well. And what you could see here is SNF-A doesn't even take, right, many of our patients, where SNF-B and C, they're able to handle our heart failure, our left ventricular assistive device patients, our transplant patients, our gender affirmation. They have, they provide methadone. We, just so everyone knows, Mount Sinai, we have one of the largest outpatient substance use treatment programs in the city. So again, a lot of our patients are on methadone and other, Suboxone and others. So having partners that are able to take these patients, right, our patients from us is really important too, not just the quality measures, but do their clinical services align with our patient population and who we are treating in the hospital is pretty critical for us as well. So interesting, to me, we were really impressed too that BNC provides such high clinical care and their readmissions are really good. Their ED utilization is really good. Their infection rates are lower and better. So, we started thinking a little bit different about how we need to consider our network. Let's go to the next slide. So we said, let's start thinking about what does quality mean for us at Mount Sinai. Length of stay at the facility is critical for us. The acceptance of referrals, right? Are you able to take our patients, right? Like I said, our stretcher dialysis patients, our methadone patients, our transplant patients, are you able to service our patients? We also have a very large Medicaid population at Mount Sinai, and as you could imagine, Medicaid reimbursement is is very challenging for post-acute care facilities, and so there is, some resistance in accepting this population, and understanding who are the partners that are willing to deal with the Medicaid population and the lower reimbursement and provide adequate services is really important to us. Again, those readmissions, both for our hospital discharges and a focus on our ACO patients, and how timely, right? We need throughput in our hospitals. So how quickly are these facilities able to move our patients as well? And so we said these are the 6 measures that are important to us out of everything that is out there. And, think about how long it took us to kind of even dive in some of the things for CMS. Imagine a patient having to do this, right? It's like so challenging and difficult for them to understand this, right? So we said, we really want to just identify quality, call it the Mount Sinai quality, and explain that to patients. We vetted facilities for you, and if you trust us for your cardiac care, you should trust us in identifying these high quality providers for you as well. And let's go to the next slide. So here, this is some real data on the facilities based on the Mount Sinai patients. And as you see here, right, when we risk adjust, because remember those really high acute patients that SNF B and C are taking, not really fair to be comparing SNF B to SNF A. B takes dialysis, SNF A does not. So when we risk adjust, right, we see a better story. The same thing on our ACO patients. Acceptances, right? So SNF A could only take 20% of our patients that we refer to them, probably because they don't have the clinical competency that the other two have to deal with our sicker patients. And then look at the length of stay, right? So they're not taking dialysis patients, they're not taking methadone patients, transplant patients, and their length of stay on an observed rate is almost 10 days higher than the other facilities. And on risk adjustment, they're still not doing very well. So let's go to the next slide. So what do you guys think? Who should we select to be in our network? Garrett, should we have you come by? There you are.
Hey, sorry about that. Yep, we got it up, and same deal as before. SNP A place. We'll give it a few more seconds. Responses are still coming in. Okay, we're going to give it about 5 or so more seconds here. We'll close it down, and then we'll share the results. Okay. All right, I think most of the results have come in, so I'm going to go ahead and end it and close it out and share the results now.
Yeah. So majority of you, almost 60% chose SNF B, and about 40% chose SNF C. It looks like, maybe one person that's chose SNF A, but majority chose B, and then C is right up there with who you would all select. So let's go back and see how that aligns with what we did at Sinai. Yeah, so we actually chose both B and C to be in our network, even though they are 2-star compared to the 4-star overall, to be in our network. And with that, should we go to the next slide? And with that, we actually have, so Marie's actually SNF B. And I'm going to hand it off to her to really talk about how it was going through the process with us at Mount Sinai.
Hi, thank you, Esther, and good afternoon, everybody. Thank you for joining us and for the audience for participating in our webinar this afternoon. So as Esther said, I work at SNF B, which is Arch Care at Terrence Cardinal Cook. We are a very large facility located on the Upper East Side, about 10 blocks away from Mount Sinai Health System. So if we can go to the next slide. So we are a faith-based holistic organization. We're part of the larger Arch Care continuing care community. We actually are located on Fifth Avenue, right across from Central Park. Initially built in 1923 as a hospital. We actually have some staff that work here in the building that were actually born in this hospital. We are quite large, 615 beds. We located on an entire city block. So we are between 105th and 106th and 5th Avenue and Madison Avenue. We've been named to Newsweek's best nursing homes in the New York City for 3 years in a row, 2020, 2021, and 2022. We have earned a Great Place to Work designation, and we are a 5-star facility for quality. So if you can go to the next slide. So what I want to really spend some time talking about is the actual 5-star rating. So my first sentence is the 5-star rating is flawed. So why is the 5-star rating flawed? The 5-star rating is a mechanism that the Center for Medicare and Medicaid Services uses to compare nursing homes. And it is heavily reliant on your health inspection score. Long-term care facilities are required to be inspected by the Department of Health on an annual basis for what's called their recertification survey. This recertification survey is the most heavily weighted portion of your health inspection score. So the health inspections are supposed to occur every 9 to 15 months. And for every deficiency within that health inspection, you do get a percentage of points based on the deficiency. The lower deficiencies obviously have a lower amount of points, and the higher, obviously, a higher amount of points. The issue is that the health inspection drives the overall quality, the overall outcome star. The problem with that is with the pandemic, all health inspections were suspended. So there are facilities that have not had survey in more than 36 months. Now you can see on the slide, those health inspection surveys are supposed to happen annually at between 9 and 15 months from your previous survey. So here for me at TCC, we were surveyed right before the pandemic in January of 2020. Our next survey did not occur until October of 2022. So that's nearly 28 months after our previous survey. So any deficiencies that you were given in that window of survey remain with you until you're surveyed again. And then each time you get resurveyed, those health inspections deficiencies that you got in the previous survey count for fewer points. So the most recent survey counts for your most points. But the problem with that is if my survey was 26 months ago and I'm still carrying those deficiencies in my overall quality star rating, that really is unfair to a facility. And there are facilities that I said that have not been surveyed in 36 months. So any deficiency they received in 2020 is still driving their health inspection star. There's also surveyor bias. Surveyors, it's not a scripted type of survey. It is a survey that there can be some surveyor bias. The focus on health inspection surveys is primarily geared towards safety, not necessarily quality, which is why the quality measures really speak more to how a facility is performing rather than the overall health inspections. And the other issue with the health inspections, it doesn't really deal with the resident or the family's experience, which is paramount in choosing a partner for a hospital. You want to know that family, that patient has had an overall positive experience, that their customer service was good, that they were responsive to their needs, that we communicated well, and none of that is reflected in the health inspection survey. The good news is that there is a pilot project called Move Forward that is looking to change the survey process and take facilities that are high-performing skilled nursing facilities and change the overall way that the surveys are conducted to really reflect on the quality of the facility, to reflect on how they respond to the needs of the families and the residents, and not necessarily just focused entirely on maintaining compliance with regulations. Next slide, please. So some of the things that Bester spoke about when you're choosing a facility that is going to be your partner. And some of the highlights here at TCC that make us very unique is we do accept a very medically complex patient population. We do have our Huntington's program, which is only one of 2 in the entire state. That's 48 beds dedicated solely to those residents that have neurodegenerative diseases. We do have 106 beds that are dedicated solely for those residents that have HIV. Some of those beds are long-term and some of them are short-term. We are the only facility in New York City that does have a methadone maintenance program. Currently, I have about 100 residents that are on a methadone maintenance program. And we also do have the ability to do Suboxone tapers here within the building. We partner with a vendor who provides psychosocial, psychological services for our substance abuse residents or opioid use residents. And they're on site 7 days a week and provide both group and individual counseling for those residents. We also take residents that do have schizophrenia. There are some facilities that will not take any residents that have a diagnosis of schizophrenia. Currently, I think right now, I think this slide could be updated a little. We probably have about 100 residents that have schizophrenia or a schizoaffective disorder. We do have psychiatry that follows these residents very closely, attempting to do the gradual dose reductions, but frequently when these patients are stable on their meds, we want to keep them stable on their meds. And we do transition some of them to the once monthly injections. So those are some of the newer medications that are out for Risperidol, Haldol once monthly. Another area that makes us somewhat unique, and I think another very good partner, is we do have smoking. We're one of the few facilities where residents are permitted to smoke within the building. We have a smoke room that is very closely monitored by a smoking monitor. We have policies and procedures to make sure we maintain safe smoking within the building. And certainly there are repercussions for residents that don't adhere to the policies and procedures around smoking. And then, like any other New York City facility, we do have residents that have many issues related to social determinants of health. I would say almost 20% of the patients that we bring in, if not more, do have some issue related to their housing. Housing here in the city is extremely, extremely challenging. We do partner with other outside organizations such as Communal Life to try and work with housing specialists to try to get housing for people once they need to transition back to the community. For some of our medically complex patients, the shelter system is not ideal for them. So we really need to think about creative ways that we can work with other organizations to find housing solutions for our residents. Our partnership also really focuses on our hospitalizations. Because of the medical complexity, we've been working years to maintain our hospitalization rates and have tried to keep pace with what's happening in the hospitals and the needs that they need in order to manage patients here within the nursing home. I think each quarter we have strived to implement a new, whether it be point of care testing at the bedside, whether it be the ability to do IV medications that are different, such as we're working on the IV inotropes now, working on IV PPIs that we can administer here to prevent residents from going back to the hospital. We're working on a very strong advanced directives and palliative care program. Jointly, we work with Mount Sinai for any resident that we believe here in the nursing home that does transition to the hospital. We do have a direct communication to the PAL care team there so that we can have that conversation restarted or ongoing if we've already restarted it here in the nursing home. So we do have our weekly meetings with the team at Mount Sinai where we really go very deeply into the ACO patients with the care team at Sinai and our care team here, talk about what the length of stay is, what are the goals, how are we going to be able to transition this patient back to the community safely so that they don't get readmitted to the hospital after they get discharged from the hospital. We've formed a partnership with our pharmacy to provide medications once patients get discharged from here, so they get a 30-day supply of meds. So they're actually going home with a bag that they have all their medications. Then they can see their PCP or go to the clinic, and then they'll be able to get their medications renewed. And then the other area that we've just started now is we've converted one of our long-term care units into what we're calling our step-up unit, which is similar to a hospital ICU. So if somebody that's on a long-term care unit is getting into trouble, we'll transition them to the step-up unit where they can have a higher level of monitoring, have registered nurses there, nurse practitioner, have walled gases, and the ability to potentially avoid somebody having to go back to the hospital because typically on a long-term care unit, you're staffed by an LPN. And then one of the biggest successes we had with Sinai as a partner was during the COVID pandemic when DOH had closed down nursing homes completely from accepting COVID positive patients. We were one of the 7 facilities in the state that DOH gave us permission to admit COVID positive residents into a dedicated COVID positive building. I think that this really helped Sinai in that really difficult period of time when they had a lot of COVID residents and beds were really, really tight. We had more than 400 residents that went through our COVID building with a very, very low rehospitalization rate. So that really helped decant Mount Sinai during a time when beds here in the city were very, very tight. Next slide, please. And then another thing that Esther mentioned is, you know, here at TCC, we do take a very high Medicaid population. We do take probably within the building, in our skilled nursing facility, more than 90% of the residents are Medicaid. Medicaid here in New York City does not even come close to matching what we are spending in the room and board for the residents. The daily Medicaid rate does not cover room and board. So we do rely upon our short-term rehab patients to sort of offset that payer mix of Medicaid. The Medicaid rate is about $300 a day. So for here in New York City, you can't imagine that you can maintain an entire Medicaid population at $300 a day. We also have a very heavily unionized environment. We have both 1199 and NYSNA. Both of those unions had contract renegotiations during the year of 2023 with significant increases in their wages related to the COVID pandemic. Their wages were increased from at a 6%, 5%, 3% rate over the next 3 years, which is significant because New York State has not raised the Medicaid rate in conjunction with what the cost of living has gone up. Currently, the Medicaid rate in New York State is based upon the cost reports from 2007. So you will see a lot of advocacy and campaigning in the upcoming 6 weeks prior to the release of the governor's budget, calling for the rebasing of the nursing home Medicaid rate to really come in line with where we are with the cost of living here in New York State. We also do have our workforce challenges. Recruitment and retention has been a significant issue. We have been reliant on agency staff since the pandemic. As a system, we've spent more than $8 million on agency staff in the year 2023 alone. And we are really, really working towards transitioning agency out and getting back into the pattern where you have your own staff. And then lastly, we do have an interesting population here at TCC. We do have a younger population, primarily because we do take the HIV patients, we take the methadone patients. We don't have an age limit on the age that we won't take a patient. The only regulation for us to have the patient here is they have to be over the age of 18. But I have residents, I have one that's 28. So if you can imagine the dichotomy of a 28-year-old versus I had somebody yesterday who turned 100. How do you meet the needs of such a diverse population in this building? So it's a challenge, and we work hard to make sure that we maintain their level of engagement. And using technology is also a way that we can do that. Next slide. And I think we talked a little bit about our collaborative programming, our COVID pandemic management together. We do have direct communication when we send a patient out 24/7. It's not always the physician that's here on site. My expectation is my nursing supervisors are calling AMAC for that handoff when somebody is going to the emergency room. And we, as I said, we have the monthly meetings, the joint meetings, and then any other time when Esther needs a bed, she just calls this phone 24/7 to see if we'll be able to take a patient and accept that patient here. And then we also, I did mention earlier, we do have hemodialysis on site, which makes it very easy, much more easier for patients to get hemodialysis if they just have to stay within the same building. And next slide.
So
I think this,
thank you,
you'll take
Marie.
this one?
Yeah, thank you, Marie.
Okay.
So as you could see, right, we realized at Sinai that we probably wanted to really zero in on how do facilities do with the patients we send them. And so we actually leverage the WellSky CarePort Connect and Insight platform now, and we actually tag and follow our patients, not just at TCC, but through almost 60 plus facilities across our geography. And we actually develop scorecards specific to the Mount Sinai patients. And we look at the readmission rate of our patients from that facility, the length of stay of our ACO patients within that building. And we also use the risk adjustment, right? As you saw, we can't really compare TCC to a facility that does not take dialysis on an observed basis. And we need that risk adjustment methodology to really understand, is TCC doing well by our patients? Because, the readmissions might be high, but again, if these are dialysis patients that whose hemoglobin is dropping and they require transfusions, yeah, they need to come back to us, right? TCC is not able to do blood transfusions in their building. So really having the insight and being able to look at, some of the measures here that you're seeing on the screen and issuing the scorecards has helped us really have communication and collaboration and quality improvement efforts across our market. And let's go to the next slide. We also, again, look at those throughput measures for us as a health system, right? So what percentage of our overall cases are you able and willing to accept? Again, focusing on that Medicaid population, as well as, how quickly are those referrals being processed. And we're able to go through, again, these throughput measures with our partners like TCC, specific to our cases, our referrals, and our admissions to those facilities. So let's go to the next slide. So looking at the WellSky CarePort solutions and being able to evaluate over 60 facilities across our market, we've been able to set up a preferred provider network of high quality skilled nursing facilities. We probably have about 25 within the 5 boroughs, Long Island and Westchester. If some of you are familiar with our market, you have to have a preferred provider in every borough because no one's going to travel bridge and tunnel to get from one area to the other. So through this preferred provider network, we've actually seen some really good outcomes. So we've had 8-day lower length of stay in our ACO for patients that go to our preferred providers. We've seen a greater than 2% reduction in SNF readmissions. And looking at the cost contribution, we've been able to reduce the SNF spend by $2.8 million in a year. So, this has been a really important project for us. We started this journey about 5-6 years ago, and I think we continue to get smarter in the way that we look at our skilled nursing facility partners and how we leverage the CarePort data that we get. Next slide. And I think we're ready for some questions.
Okay. Yeah, we have some questions. They start by saying, great presentation, thank you. Could you share more about the scorecards you developed and how do you approach SNFs with them?
So as I said, we actually work with CarePort to get back our own data. And so for our ACO patients, for instance, we load our attribution files into CarePort so we could track our patients. And as Marie and TCC are not the only facility, but we actually meet monthly with a number of facilities, and we have standard metrics that we look at with them. And we trend, as you saw. So we look at the readmission rates. And if we see that they're trending in the wrong direction, or if they're worse than we expect, we could, out of Careport, also pull patient level data and do case reviews from both sides to see what could have been done better. Again, sometimes these patients are coming back to the hospital, and what we're finding is within 3 days, and it could be that maybe we prematurely discharged the patient, or maybe our handoff to the facility wasn't right. So we really do look at it on how do we improve quality of care from both sides. We don't just put the onus on the skilled nursing facility. We look at what did we do that might have contributed as well. So readmissions is a big focus, again, with that risk adjustment and ensuring that the facilities see that, yes, you may be at a 30% readmission rate on an observed, but I recognize that you take vent patients. And that's why your risk adjusted is actually showing that you're performing better than expected. So weighing that and having that conversation, because I think it could be, jarring to a facility to look at 30% readmission rates, but we have that conversation, right? You are a vent facility, and this is why we have your risk adjustment here that is showing that although observed you're high, risk adjusted you're doing well. Same thing on length of stay. We do case reviews as well. Every week, we actually review with them how patients are progressing to that target discharge date and discuss any variance that we're seeing. And again, what could have the facility done better if they missed that target date? What could have been coordinated better on the onset? Could the family have come in earlier to do transfer training or wound care training? And we make sure that in the next case. And so it really is, it's not just about giving them a scorecard and yelling at them, telling them all the things that they're doing wrong. I think, just so everyone knows, I came from the post-acute care side. So when I came to the acute care side, I took those things into consideration. And we really drive at what could we be doing better together versus just what could the facility be doing better. And I'll speak to Marie because she gets these scorecards every month from us.
Yeah, I would agree completely. And the scorecard is one thing, but the real work happens on the weekly calls with the team to really, as Esther said, to talk about how the patient is progressing, and then really putting together what we can, if we can, a discharge plan, but then understanding that there are times due to housing insecurity that somebody may need to convert to a long-term care resident. So then we just walk through the process of making sure that everything is updated so it's not really affecting those metrics related to length of stay for the ACO patients. So it's really a collaboration and ongoing communication, not just getting a monthly scorecard that says, oh, you're not doing as well as we expected you to. And we frequently are emailing back and forth about different patients that we have in common. Some of the cases that are very challenging related to their economics, their socioeconomic issues. So it's really more than just a scorecard.
Great. Well, let's move along. We have time for maybe more questions if we have quick answers. Next question is this. It starts by saying thank you for great information shared. For MSSP ACO SNF network, does it need CMS approval of which SNF can be part of your network? And if yes, is the overall star rating not a consideration then for them to approve a SNF to be part of the MSSP ACO network?
Correct. You do not need CMS approval for a facility to be in your preferred provider network. I do want to, though, just say that if you are applying a waiver, CMS does have requirements related to a waiver, but our MSSP does not use the 3-day waiver, so we're not limited to the star rating.
We keep having questions pour in, and this is awesome. Unfortunately, we are out of time. So if you have a question, go and you haven't had it answered yet, please go ahead and ask it. Continue to, even as we're closing out. Someone will reach out to you through email afterwards to answer your questions. So keep them coming. And thank you all so much. This is obviously a great topic. Thank you, Marie and Esther, for a wonderful presentation today. This was fantastic. And I really love how you guys worked to engage the audience and teach us some really valuable things that we may not have seen coming. So thank you so much. As we close out, I wanted to encourage you all to head over to WellSky, which is formerly Careport, and check out their virtual exhibit booth at vbcexhibithall.com. You're going to see a lot of their resources where you can read up on them, what they're doing, how they're able to potentially help you in your organization, or you can just kind of read up and again educate yourself on what they're doing in the value-based care space. And just real quick, since we didn't get a big intro on WellSky, I just wanted to read this real, as kind of an intro of what they do. WellSky provides an end-to-end platform bridging acute and post-acute EHR data and providing visibility into the entire patient journey for providers, physicians, payers, and ACOs. So they obviously have a lot to offer. So head over there to learn more. There'll be a link there. And then finally, if you'd like to reach out to the WellSky team, or if you'd like to get in touch to ask any further questions to either of our presenters today, you can reach out to them. Can I have you go to the final slide? Okay, so you can reach out to, there's an email there. I'm going to send out a final email to everyone who registered today, even if they weren't able to attend. And there's going to be a link to the recording, as well as where you can download the slides from today's presentation. So again, thank you all so much for joining us. Thank you, Esther. Thank you for Marie. Hope you all have a wonderful rest of your weeks and a great holiday.
Thank you. Bye-bye.
Bye-bye now.